Welcome. I'm Dr. Phil Schauer, Director of the Minimally Invasive Surgery Symposium, otherwise known as MISS. I'm here today in this beautiful venue in Las Vegas with my good friends, Dr. John Marks and Dr. Morris Franklin, and we are celebrating the 16th anniversary of MISS. We are about to begin the program, and I have these two our co-directors here who are running the colorectal program here to make some comments about MISS and in particular talk about some of the really hot things going on in minimally invasive colorectal surgery. Morris, I think you've been to most of these meetings, going back to some of the very first meetings over a decade ago. It's great to have you back. What are some of the things that come to mind when you think about MISS and what type of information we deliver to surgeons?
Phil, I think that the major thing that you provide is a good interactive forum rather than a lecture, this is the way you must do it, to this is the way I do it, what does the people in the audience think? I know that I've already seen a number of people who have been at this meeting before, and they look forward to the interaction between the faculty and themselves, and I think it really brings a good question and answer forum that is not present in a lot of national meetings.
Well, Morris, I appreciate that. And you know, just feedback from our audience, we have surgeons that come to this meeting who are experts themselves. And I've noticed I have left the meeting learning a lot just from comments and suggestions from the audience, so that back and forth interplay seems to be something that's very valued.
And Phil, I think that
John, yeah.
It really is, you know, for me, what makes it fun to come is not only to hear and see my good friends and great faculty members, but the quality of the expertise in the audience is so high that, as Morris said, it's kind of a 360-degree discussion as opposed to just from the podium out, and that's what makes it fun. And I think that's why there's so many, you know, return attendees.
Yeah. And I've gotten a lot of comments, particularly about the faculty, you guys, and the guys that you bring to this meeting that seem to be so approachable. Unlike perhaps other meetings, in between breaks, having some coffee together, a lot of very valuable information is exchanged, and it seems that the faculty is very approachable.
As you and I discussed 10, 12 years ago, Phil, when we first started the colon portion of this meeting, we really needed to have faculties who were great teachers and great communicators and had the experience. That's hard to find. Right. There are people that are good lecturers, and there are people that are pretty good surgeons, but having that good combination where we can really interact with the people that are attending, I think makes all the difference in the world, in the quality of the meeting and the educational experience of all of us, as John said.
That's a great point. And what I love about the program you guys have put together, like past programs, you've been able to combine topics of a wide variety, things that are very important in terms of the science, but also really practical things that tips and surgical techniques that these surgeons will adopt, and within a week or so of the meeting, they'll start incorporating into their practice.
There's no question about it. I mean, this is a group of doers, not talkers. And so, you know, in putting together the faculty as well as the curriculum, that's been at the forefront of Morris and my thoughts. And, you know, I really followed the path that Morris has etched out previously, trying to have a lot of good anatomy, you know, controversial things, what we think from what we've seen and done the future's going to be, kind of the near future, not kind of pie in the sky stuff. And then a lot about how I do it, what are the challenges, and trying to pick people who do things differently, both with good outcomes, because that's the type of kind of rich discussion that I think everyone enjoys.
Excellent. Well, to that end, there's lots of great subject matter on this year's program. Tell us, maybe Morris, you could start, what are some of the really hot topics now in the colorectal world?
Well, I think all of them are still hot topics.
Yeah.
Because if you look at nationally at the statistics and worldwide, the number of pure laparoscopic procedures that are done for colon surgery is actually still pretty low. It's way less than 50%. So I think just getting there is part of the challenge, and that's part of the topics that John has brought together. I think he's done a masterful job again this year of bringing some of these things to the fore. It's stuff that's old to us, but it's stuff that's new and challenging to the guy that's out there. So what we're trying to do, for the most part, is make it simple so that they can adopt it, again, as
Right.
John has said.
Well, Morris, I mean, you were there clearly one of the key pioneers many years ago. I think you did the first or second laparoscopic colectomy on the planet. So you've seen this whole thing develop. What do you think have been some of the key advances in terms of going from 0% adoption to 50%? You say it's not where it should be, but we still have come a long way. What are some of the key? Is it certain trials that have been published, or is it skill development, or a combination of things?
I think skill development has been one of the big things. With the exception of certain medical centers, the medical centers have really drug behind and have gotten there kicking and screaming. Institutions like John's and like yours have been at the forefront of moving things forward, something that started in private practice, much like minimally invasive surgery started in private practice, is now being taught, albeit reluctantly in some places still, to keep people in the mainstream. And for a surgeon to finish a residency and not have any experience in laparoscopy puts him way behind the eight ball. And 8 or 10 years ago, that was the commonplace rather than the exception.
Well, they wouldn't survive. I mean, it's absolutely necessary, and that's for one reason why many surgeons are doing a fellowship, whether it's an MIS fellowship or doing, colorectal and trying to get that MIS experience.
Well, it is the truth. I mean, we had a colorectal fellow in a board-accredited program come visit us a few years back, and they did their colorectal, but their laparoscopic cases, but not many, and he was friends with our fellow who was doing an MIS fellowship, and as Morris has, and so he's in the room. I asked him, what do you think of laparoscopy? And he said, well, I don't really like it. I like open surgery. To which I said, well, you picked the wrong field, son. But I think really,
if you want to have a future.
Right, I think that really, there's no question that this is, at this point, it's kind of past the tipping point. There's no way to turn back. And it's really the type of programs like this that have, gotten us from there to here, and are going to help us get from here to where we want to get in the future, which is higher adoption and better quality of surgery. There have been a lot of discussions over the years, like quibbling as to, well, is laparoscopy, hand assist, what's the role of the robot? But really, the whole question should be, how do we go from 0 to 10 to 50? It should be around 80 to 90% of things should be done in minimally invasive forum, and this is the way we've done that. And I think by introducing to the group some of the advances that have happened in robotic surgery and colorectal surgery, as well as the transanal TME and endoluminal surgery, are really kind of hot topics that aren't exactly here at the moment, but are kind of coming down the road.
Well, maybe you speak that more, because I wanted you to talk about some of the really hot topics on the program, and the transanal thing has seemed to be really catching a lot of interest in the colorectal community.
Well, I think it is an exciting path. I think it's something that's in really its very nascent stage. And it's not going to be for everyone, because it is difficult, and you have to do a high volume of rectal surgery to do it, on the one hand. On the other hand, just like everything, it moves everything forward. I mean, you're basically doing single incision surgery, node surgery through the anus, and it's making the most difficult part of rectal cancer surgery more accessible to more people. And I think that, but again, it's like going back to the, 90s in the gallbladder and the late 90s in colon surgery in terms of teaching people and how to do it well, because of course the goal, as I think Morris said so long ago, is to do the case perfectly, not to do it laparoscopically.
Well,
although he does
Morris,
both.
Well, and I've got to give Phil a little bit of credit, because Phil has
Reluctantly.
Phil has allowed us to put a faculty together, John, that you and I know, that we know are good teachers to start with, but they're also approachable. They're approachable not only during the meeting, but we walk away from this meeting and the attendees walk away from this meeting knowing that they can call any one of us at any time, and we'll try to give them the best advice we can. And it may be, don't do it. It may be, what are your facilities like and what's your backup like before you start this? And I think giving both sides of the story for any given subject, like this time we're going to be talking about perforated diverticulitis, and there's been some negative articles come out that we're going to be talking about during the lectures that the attendees will walk away with, saying, well, I don't know if I want to do that, but on the other hand, there's guys, for example, in Louisiana and Alabama that have done 150 perforated diverticulitis and are extremely happy with it. So we'll be talking about that. We'll be talking about it, the transanal stuff. We'll be talking about all the other aspects that are actually changing, as well as some of the stuff that has still coming back. Like I know Larry Whalen's given a nice talk on some of the immunology, which I think is incredibly important.
Yeah.
Well, you know, I think just one thing I wanted to jump in there with is that the faculty is a bunch of enthusiasts and skilled enthusiasts, and that comes across, and that's why they're approachable, because they're students of surgery and love surgery, and they love to perform it and do it very well. And, you know, I think that's to everyone's benefit to have them up front speaking.
Yeah, very good. Well, some of the controversial things, you mentioned rectal surgery and, cancer, and, several years ago it was controversial about doing, laparoscopic colon surgery for cancer, and the randomized trials have shown that for colon surgery, it's safe and there's some advantages. But for rectal, right, and now we have 2 randomized trials came out this year, one from Australia, United States, that a little bit dicey in terms of the outcomes. Can you comment on that? I know this will be discussed a lot this week.
No. I can't comment on a public forum where it's going to be recorded.
Ladies and gentlemen, you're going to hear it, and guys like Morris and John tell it like it is, okay? So while you may not be public about it on this video, I'm sure at the meeting you will share your real thoughts about these trials.
Yeah, the trial is only as good as the people involved in the trial. And what a randomized prospective trial does is lowers it to the lowest common denominator. We have to keep that in perspective.
Okay.
Well, I think also that the real reality is that those trials didn't prove anything. I mean, it was basically a negative trial. It didn't prove that laparoscopic TME surgery was poor. They tried to kind of get in under the wire and not wait for 2- and 5-year follow-up by using a surrogate marker of TME completeness for local recurrence. And in my opinion, in 3 years, when the actual pathologic data comes out, it's going to be fine, because it trended all right. The numbers just weren't right. I think there were some structural problems.
And the main endpoint was these surrogate markers like lymph node, number of lymph
it was
nodes.
completeness
And the completeness of
TME,
resection, right.
And they came up with this new aggregate number that there had to be a 6% difference for it to be considered non-inferior, and there was less than a 6% difference, but both groups were less than the original target, so the statistician said it doesn't meet the criteria. I mean,
so the results of these studies are a little bit muddy. I think the beauty of MISS is bringing these experts together who can really talk to surgeons in practice about what these mean.
Morris and I are still going to be doing these.
Okay, there you go.
Yeah. No doubt about that.
Very good.
And what the studies really showed was that rectal surgery can be difficult whether you do it open or laparoscopically. Hopefully John's ideas and the things he's been promoting for the past 20 years. Are you 20 years old? At least 20 years may have more merit than was originally suspected.
Great. All right. Well, gentlemen, thank you for sharing some of your thoughts about MISS and colorectal surgery in general. And for the audience, I guarantee you, coming to this meeting, you're going to be able to hear these controversial subjects from surgeons who really know a lot about this area, who are going to tell you straight about what you should be doing in your practice. So,
well, thanks so much for having us, and it really is a wonderful event for those of you who have been here, and for those of you who haven't, you'll love it.
Great.
You demand. Edit it out.